welcome to my video. This is my first ever healthcare video, so I'd very much appreciate a big thumbs up. I'll try my best not to make this video too long. Today I'll be focusing on the effects of glucocorticoids and the types of therapy available. The video will be divided into various sections, so feel free to skip to the section that would be most beneficial to you. First of all, I'll start off by giving a brief introduction on the location of where the adrenal glands are and their purpose in our bodies. So, above the kidneys, there are paired glands, also known as the suprarenal glands. The glands are surrounded by a dense connective tissue and have two concentric layers. These layers are the adrenal medulla and the adrenal cortex. So, upon stimulation, the purpose of the adrenal medulla is to secrete catecholamines. For example, norepinephrine and epinephrine. These are the fight or flight hormones that are usually released when the body is under extreme stress. They can affect the heart, blood sugar levels, and the blood vessels. Whereas when the adrenal cortex is stimulated, it secretes adrenal steroids. It's composed of three layers in total. So firstly, you've got the outermost layer, which is the zona glomerulosa. This releases mineralocorticoids, for example, aldosterone, which primarily affects the body's regulation of blood pressure. The second layer is the zona fasciculata, which releases glucocorticoids, for example, cortisol, which we will be focusing on today. And then the third layer, you've got the zona reticularis, which secretes adrenal androgens. Now I'll talk a bit about the pathogenesis of the release of adrenal hormones. So it all begins from the hypothalamus. The hypothalamus is stimulated via neurotransmitters, which could be from stressors or the body's circadian rhythm, which is the normal sleep and wake cycle. The hypothalamus secretes corticotropin releasing hormone, which is passed through the hypophyseal portal system. The corticotropic releasing hormone acts on the corticotropes in the anterior section of the pituitary gland. The pituitary gland then secretes adrenocorticotropic hormone, which, as you probably already guessed, travels through the blood and targets the adrenal cortex. This then enables the adrenal glands to secrete their hormones accordingly. So why are glucocorticoids important for the body? Like how we mentioned earlier, cortisol is the main glucocorticoid in the body. The levels of cortisol increases naturally in the morning and drops in the evening. Cortisol is usually bound to cortisol binding globulin in the blood before it reaches the target cell, and any excess of free cortisol is filtered in the kidneys and excreted via the urine. High levels of cortisol can signal back to the hypothalamus and the anterior pituitary gland in order to reduce the amount of corticotropic releasing hormone or adrenocorticotropic hormone. This is also known as the negative feedback loop. There are also a wide range of pharmaceutical synthetic compounds that patients can administer to mimic the effects of glucocorticoids. The two major roles of glucocorticoids are metabolic and immunological. So, in the metabolic role, cortisol serves to increase and maintain the normal concentrations of glucose in the blood. This is usually when a person's in a fasted state. Some metabolic effects include fat breakdown, gluconeogenesis, and proteolysis. In terms of its immunological role, it's classed as a powerful anti-inflammatory agent. This is because it reduces the release of inflammatory mediators such as prostaglandins and leukotrienes. I'll first briefly explain the two pathways of the body's response to inflammation and then talk about the glucocorticoids, how they alter the pathways. So the first pathway begins with pain, inflammation or infection. There is stimulation of cells via receptors. This then causes activation of nuclear factor kappa B within the cell. The nuclear factor kappa B activates the genes of the cell. Then there's production and translation of messenger RNA to inflammatory cytokines. And then finally, there's stimulation of inflammatory response promoting inflammation. In the second pathway, there is the inflammatory response, the initial inflammatory response. The phospholipid membrane of the cell is converted into arachidonic acid. Then arachidonic acid is converted into prostaglandins, leukotrienes and thromboxans via the cyclooxygenase enzyme, just how I've drawn here. So in this pathway over here, glucocorticoids enter the cell. It binds onto the glucocorticoid receptor. It then inhibits the nuclear factor kappa B, making it inactive. This inhibits the production of inflammatory cytokines and thereby suppressing the immune system. And in this second pathway, there is inhibition of phospholipase A2 and cyclooxygenase enzymes, which then in turn blocks the inflammatory response. Now that we've briefly gone through the role of glucocorticoids, I want to focus a little on synthetic glucocorticoids. So why would there be a need of glucocorticoid therapy? So indications for therapy can be divided into endocrine and non-endocrine. For endocrine, the reasons for initiating therapy would be due to adrenal insufficiency, which could be acute or chronic, or adrenal genital syndrome. This is also known as replacement therapy, as the adrenal glands cannot produce enough cortisol. And for non-endocrine, it's indicating for the following purposes. So you could have anti-inflammatory effects of the therapy, as it reduces tumor necrosis factor alpha and interleukin 2. It's used in arthritis, osteoarthritis, ulcerative colitis, nephrotic syndrome and ocular diseases. It could also be used as immunosuppressive therapy, as it reduces interleukins 1, 2 and 6 along with tumor necrosis factor alpha. Here it could be used in hematological diseases such as autoimmune hemolytic anemia and certain malignancies along with transplants. It could also be used to decrease calcium levels, as there's hypercalcemia in certain malignant conditions, although this is really uncommon in practice. Other uses for glucocorticoids include anti-allergies, so for example in severe allergies and bronchial asthma, or it could be used as a diagnostic measure, for example the dexamethasone suppression test. So what compounds are out there in the industry already and how do they differ from one another? There are a variety of synthetic glucocorticoids out there. Some are far more potent than cortisol itself, which have been modified specifically for their therapeutic use. They tend to differ in both pharmacokinetics and pharmacodynamics. As they are able to permeate the intestines easily, they are commonly administered orally, but can be administered via other routes such as intravenous, topical route, rectal route, and via inhalation. So glucocorticoid potency and duration of effect varies. Cortisol, when some sources refer to as hydrocortisone, is the standard comparison for glucocorticoid potency. So, for example, if we mark prednisolone as to having 5 milligrams as the potency value, we can compare the amount of other steroids needed to equate to that. For example, methylprednisolone, 4 milligrams is needed to equal to the amount. Dexamethasone, 750 micrograms is needed, which makes it highly potent. For betamethasone, again, 750 micrograms is needed, which also makes it highly potent, and hydrocortisone, 20 milligrams is needed. Hydrocortisone itself has a relatively high mineral corticoid activity, so therefore results in fluid retention, making it unsuitable for disease suppression on a long-term basis. Okay, so there are different durations of effect for synthetic glucocorticoids which would need to be considered when prescribing. So you can get short-acting, such as hydrocortisone, which is usually given in emergencies, acute adrenal insufficiency, status asthmaticus, or anaphylactic shock. Intermediate acting, such as prednisolone, which is commonly given as an anti-inflammatory, immunosuppressive, and anti-allergy. And finally, long-acting, for example, dexamethasone and betamethasone, which, as we've mentioned earlier, are highly potent. The withdrawal of steroids is a highly important factor as well to consider when prescribing to patients. The reason being is because the use of high-dose steroids for more than a week begins to produce suppression of the patient's adrenal glands. The exogenous glucocorticoids suppress the hypothalamic corticotropin releasing hormone and pituitary, along with the pituitary adrenocorticotropic hormone. With prolonged suppression, the adrenal glands become more atrophic, so they physically shrink. And this can take months to fully recover after discontinuation of the exogenous glucocorticoid. During this recovery time, the patient can become more vulnerable to adrenal insufficiency during times of stress, such as illness. Clinical guidelines have thereby been devised to estimate the potential adrenal suppression and recovery to reduce the risk to the patient. So, for example, if a patient has been receiving daily high doses for 5 days or less, they can abruptly stop. Full adrenal recovery can be assumed to occur by a week afterwards. But if a high dose was used for 6 to 10 days, they must reduce to replacement dose immediately and taper over 4 days. Adrenal recovery can be assumed to occur within 2 to 4 weeks of completion of steroids. And also, flare-up of underlying condition for which steroids are given may require more of a gradual taper. Finally, I'll finish off with the side effects of glucocorticoid therapy. So, as I mentioned earlier, cortisol affects the metabolism. Therefore, the side effects of steroidal treatment primarily target certain metabolic cascades. So for effects of carbohydrate metabolism, it can cause exacerbation of diabetes, hyperglycemia, and cataracts. For protein metabolism, it can cause muscle wasting and peptic ulcers. And for fat metabolism, it can cause abnormal fat deposits. A common side effect of patients being on long-term corticosteroids is the patient themselves having a moon-like face feature. This is due to fat being deposited in the cheeks. The patient would also gain a lot of weight. Glucocorticoids can decrease the amount of calcium, which can lead to osteoporosis and necrosis of the femur head. It's also known to inhibit the osteoblasts, which in turn inhibits the formation of the bone. Blocking the inflammatory pathway can itself bring along some side effects, such as formation of peptic ulcers. This is due to the decreased prostaglandin synthesis. Also, as we are suppressing the immune system, there would be a high chance for the patient to develop opportunistic infections. Thank you for watching my video, and hopefully you've learned something from it. I do apologize if I've missed anything out. Please comment on how I've done and subscribe to my channel. Thank you.